Hello and welcome to the Canadian Digestive Health Foundation's presentation of Understanding Your Options for Managing Chronic Constipation. My name is Catherine Mulvale and I'm the Executive Director for the Foundation. Thank you for joining us. The Canadian Digestive Health Foundation is here to help you. We are the foundation of the Canadian Association of Gastroenterology and are supported by physicians and scientists who specialize in digestive health and disease. It is our mission to empower people like you to take control of your digestive health with confidence and optimism. Our objectives this evening are, first, to welcome you and let you know that as someone interested in constipation, you are not alone. Next, we want to introduce you to Dr. David Armstrong, a gastroenterologist who is here to help you better understand constipation, what may be causing it, and learn more about how you may find relief from this uncomfortable condition. And finally, we're here to answer as many of your questions as possible. The Foundation would like to thank Janssen for sponsoring this event with an unrestricted educational grant. Without their support, this session would not be possible. We hope our session will provide you with valuable information that you can use in your everyday life and when speaking with your healthcare providers. Our expert leading the session is Dr. David Armstrong. Dr. Armstrong is a graduate of Churchill College, Cambridge University, and King's College Hospital. After spending 2 years as a family physician in Labrador, he completed his medicine and gastroenterology training in the UK, Switzerland, and Canada. Dr. Armstrong's clinical and research interests include upper gastrointestinal disease, inflammatory bowel disease, or IBD, nutrition, cystic fibrosis, education, and practice audit. He has over 150 peer-reviewed publications and 80 articles. Our presenter has been a medical director of the Hamilton Health Sciences Home Parenteral Nutrition Program since its inception in 1997. He is a member of the board of directors of the Canadian Digestive Health Foundation and will be the future president of the Canadian Association of Gastroenterology. Dr. Armstrong is chair of the Canadian Association of Gastroenterology's Endoscopy Committee, and he's the inaugural CAG visiting clinical professor for 2012 and 13. When Dr. Armstrong is not leading gastroenterology initiatives, taking care of his patients, or conducting research, he happily spends his time with his wife and 5 sons. Dr. Armstrong will share some of his insights with you to help you better understand what constipation is and is not, the causes of constipation, options that are safe and appropriate for treating the condition, and provide you with some guidance on how to speak to your physician about constipation. Now I'll turn it over to our expert. Welcome, Dr. Armstrong.
Good evening, everybody, and thank you very much to Catherine for the introduction and for giving me the opportunity to talk to you about constipation, as we'll allude to in a minute, not necessarily everybody's favorite topic of conversation. What I want to do is to start off and address some of the realities of constipation, but before that, there are some disclosures here, which is effectively to say that I've worked with a number of companies and organizations that have an interest in or medications for constipation, including Abbott or AbbVie, Ferring, Janssen, and Pendopharm. So what you should see here is constipation. What is it? And I think, as I mentioned before, what it is not perhaps is anybody's favorite topic of conversation. It's unfortunately something that many people suffer in private with, and it tends to elicit this sort of reaction when the topic is brought up with friends and or relatives. And one of the problems with constipation is that people tend to suffer in silence, and bringing the topic up tends to elicit this sort of reaction from people with whom one wishes to discuss constipation. So that brings us really to the topic of what is constipation. And constipation means different things to different people. And so I want to take a couple of slides just to address this. If you look up constipation in a dictionary, such as a standard medical dictionary like Stedman's, this says that constipation is difficult, incomplete, or infrequent evacuation of dry, hardened feces from the bowels. That is part of what constitutes constipation, but that really doesn't give the full picture, and it's very difficult to use that for clinical studies, for clinical care. And so there's a working group. There are people who've taken a lot of interest in this and what are called other functional disorders. They met initially in Rome, and they developed definitions and study criteria for looking at a number of different conditions, including chronic constipation. And so what we have here are what are known as the Rome 3 criteria for chronic constipation. So this is another definition of constipation, which says that the symptoms should be present for at least 6 months prior to diagnosis, that they have to occur at least 3 months out of the last 12 months, that there has to be straining, lumpy or hard stools, a sensation of incomplete evacuation, that is the feeling one still needs to go, having passed stool, a sensation of obstruction or blockage in the anorectal region. For some people, the need for manual maneuvers to actually move the stool, and having less than 3 bowel movements per week. This definition says that loose stools rarely present without the use of laxatives, and that this definition of chronic constipation is for people who do not have a diagnosis of what's called irritable bowel syndrome. Now, I'm not going to talk for this evening about irritable bowel syndrome, but there is overlap, and there are people who have IBS or irritable bowel syndrome for whom chronic constipation is part of the group of symptoms that they experience. So this again is another definition, and this is very much more detailed, and in practice is very difficult to use in day-to-day life, and it's not certainly something that one would be expected to describe in detail when talking to a physician or to a healthcare professional about constipation. And I think really a simpler way of looking at this is to look at the basic symptoms of constipation and to understand, as this slide points out, that even if you take a simpler definition of constipation, there are different viewpoints on this. And what we'll be doing is looking at it, if you like, more from the patient point of view, which is that for most patients, constipation is part of a group of symptoms. There may well be infrequent stools, there may be straining, and a feeling of incomplete evacuation, but there are also other symptoms like abdominal discomfort, bloating, distension, and for many people, gas or flatus. And it's important to recognize these symptoms because the studies and physicians' view of this is often more related to a view of constipation as being infrequent stools. And so physicians or healthcare providers, nurse practitioners may ask rather, how often do you move your bowels, or how often do you go to the bathroom, and define whether or not there's constipation based on whether or not you go more than 2 or 3 times a week. Now, this is an important part of constipation, but for many of us, it's not the only symptom, and it's really the other problems, the straining, the bloating, the discomfort that is often the issue that needs to be addressed. And so that's really a sort of introduction to constipation, and the key point from this is that there are a number of symptoms related to this, not just how often one goes to the bathroom. What I want to do over the next couple of slides is to look at why it is that we get constipated, and to look a little bit about the anatomy of the bowels, the structure of the bowels, and to explain why this happens. But before we look at why people get constipated, what I wanted to do was to emphasize that this is a very common condition. So what we have here is a map of Canada. The population of Canada is about 32 million people, or 34 million in fact, and of that, about 25%, 27% in fact, more than 1 in 4, will report symptoms of constipation. So this is not an uncommon or isolated problem. This is something that affects 1 in 4 people. And so you can imagine that at any social gathering, there are likely to be a number of other people who are suffering the same problems. To understand what constipation is, I think it's helpful to understand the structure of the bowel, or what we call the gastrointestinal tract or gut. And if we look at this, you can see at the top of this picture, when we eat food, it goes from the esophagus through the chest into the stomach, which is a sort of reservoir that holds on to food before it moves down the small bowel where most of the nutrients are digested and absorbed. And in this picture, the small bowel is sitting in the middle of the abdomen, and then at the bottom left, looking at this picture, which is actually the right lower part of the abdomen, is the start of the colon or large bowel. And you can see here there's a label that says appendix, which is at the start of the colon or large bowel, which then goes up the right side of the abdomen, across the top, and then down the left side, and then takes this stepwise approach through what's called the sigmoid colon into the rectum and then down to the anus, where stools are pushed out when we have a bowel movement. And it's this large bowel or colon that does much of the work in removing fluid from digested food, and it's here that the symptoms and problems related to constipation will often arise. And one way of viewing the large bowel or and the way that it works is to view it as a conveyor belt, which takes liquid content, and you can see here there are numbers. 1 says intake, 2 says transit, and 3 says outlet. So what happens is liquid content comes out of small bowel into the start of the large bowel, where the number 1 arrow is, and then it goes up and across. And as it moves around, rather like moving along a conveyor belt, the body and the lining of the bowel or the lining of the colon then extract water. So they're like little arms or little sort of transport mechanisms that pull water out of the stool. And as it goes around, it becomes progressively less liquid. It becomes firmer gradually as it goes around the bowel. And in time, it will usually become solid. And if it stays there, even more water is taken out, and it then becomes hard and difficult to pass. So the rate at which food goes through the large bowel, the rate at which the water is taken out, and the way that this is controlled, all of these play a role in producing constipation. And that's why dealing with constipation and why it occurs is both simple. It's really a conveyor belt that allows the body to extract water from digested food, but it's also complicated because there are many different things that will alter how quickly the contents go through the large bowel or through the colon, and that will affect the rate at which the water is taken out and how often we move our bowels. And that's where the opportunities come for treating constipation. In trying to determine whether or not constipation is a problem, there are a number of things that may lead to the different symptoms of constipation, and there are a number of different descriptions for those symptoms. But one of the things that's helpful is to be able to describe to your physician or healthcare professional, healthcare provider, what it is that the problem is. And part of that is illustrated in this, which is called the Bristol stool chart, which points out the different forms of stool. And being able to describe this in a reasonably standardized fashion to your physician is helpful in understanding, allowing your physician to understand what the problem is. And so what we see on the left-hand side is 7 little graphics which are designed to classify the form of human stool or feces in such a way that your physician can understand what it is that you're passing and what are potentially some of the problems related to the symptoms you're having with constipation. And in general, types 1 and 2 up at the top with these little hard pellets or hard stools are what are considered to be constipation. Types 3 and 4 in the middle are generally considered to be relatively normal stools, although people still may have constipation if they find it difficult to pass these stools or find that they have to strain to do so. And then at the bottom are the looser stools that are associated with diarrhea. And this may be what happens when people take laxatives or too much laxatives to try and deal with symptoms of constipation. So in trying to deal with constipation, as I said, it's in a way one can reduce this to several relatively simple steps, and these are illustrated here. Constipation is more likely if there is poor intake. That means that if you're taking relatively small amounts of fiber and relatively little that provides bulk to the stools, what will happen is this description here, which is I pass very small amounts of stool, but generally regularly. And that's often a symptom of poor intake of fiber and other foods that will tend to bulk up the stools. There are patients who say, I never get the urge to go, I get progressively more bloated and distended, and that's often related to slow transit, which is that the stool, the colon contents are moving slowly along the conveyor belt and therefore tend to get held up, allowing more and more fluid to be extracted so that the bowel becomes progressively more distended. And then there are people who say, I always get the urge to go, I strain and strain, but very little happens. And this is a small proportion of people, maybe 10 to 15%, who have what's called outlet dysfunction. And this may relate to abnormalities of the nerves or the muscles or stool behavior, which mean that despite the urge to go and despite straining, the anus and the rectum don't relax properly and are not able to expel the stool properly. And this is a different mechanism from the slow transit or poor intake and may benefit from a different approach to treatment. Now, there are a number of things that are associated with an increased risk of constipation. This doesn't mean that everybody in these groups necessarily has constipation, but as we get older, we tend to be more likely to become constipated, possibly related to changes in diet or into and changes in exercise, but possibly also related to other things that change in our lives. So as we get older, we tend to have less physical activity, which increases the risk of constipation, inadequate dietary fluid or fiber intake, some medications, for example, painkillers such as opiates, things like Tylenol 2s, 3s, all of these contain opiates that slow down the bowel and increase fluid absorption. Calcium supplements can tend to cause constipation. People who've had recent abdominal or bowel surgery are more likely to get constipated. And people who've had a long history of prior constipation or laxative overuse have an increased risk of becoming constipated as well. For many of us, and this is not necessarily chronic constipation, but travel, changes in lifestyle can produce changes in bowel habit, and that may be either acute or chronic. In late pregnancy, constipation is rather more common. And then there are a number of other general medical conditions like thyroid disease, particularly underactive thyroid gland, or diabetes, sugar diabetes or diabetes mellitus, that are associated with an increased risk of constipation. And again, this doesn't mean that most people with constipation have any of these, but they're all factors that can make constipation more likely, and many of these can be addressed to reduce the risk of constipation and deal with many of the symptoms. Now, for most people with constipation, it's not actually a serious condition. It's unpleasant, it's uncomfortable, and of course one wants to be able to regularize one's bowel habit so that one feels more comfortable and is able to get on with a normal day-to-day life. A small proportion of people, constipation is an indication of something more serious, but if it is something more serious, then there are usually other signs or symptoms that we have to watch out for. And the sort of things that we're watching out for are listed on this slide. These are sometimes called red flags or alarm features. So anyone who has rectal bleeding, whether or not it occurs at the time of passing stool, this needs to be investigated. And that's not just for people who have constipation. A recent change in bowel habit, particularly if there's no obvious explanation, such as a change in medication or change in lifestyle, needs to be investigated or considered further. Increased constipation symptoms in patients or people over the age of 50, and particularly if the constipation is associated with abdominal pain or symptoms of blockage, that is progressive abdominal distension, fullness, nausea and vomiting, patients who have unintended weight loss, people who become anemic, that is their blood levels stop, reduce, change in stool caliber, and particularly a family history of colon cancer, particularly if it's a first-degree relative like a mother, father, brother, sister, or child. All of these things raise or increase the possibility that the constipation may be associated with another condition that needs to be investigated. So it's well worth and really important to look out for these signs, these alarm features or red flags. Having said that, most people do not have any of these, and if you don't have any of these, then it's entirely reasonable to look at some of the other management strategies that we'll talk about in a couple of minutes for dealing with constipation. I want to spend a few minutes or a couple of minutes talking about constipation in children. This, again, is common. It is more often acute, that is short-term than long-term. But the problem for children is if they have an acute episode of constipation, for example, related to fever or a cold or a flu, that may then put them off going to the bathroom so that they then are afraid to pass stools because they've had an episode of constipation, and this can lead to behavioral changes that may lead on to chronic constipation. And these are the kids who will tend to deliberately or subconsciously prevent themselves from passing stool. There may be other reasons as well. It may be that they don't want to interrupt their playtime. For many kids, going to the bathroom is actually just boring. They may be embarrassed to use a public washroom. Or, as I said, they may be afraid to have an unpleasant bowel movement because of previous bad experiences. The causes for some of this may be related to diet, and many of the things that children like best are low in fiber and are likely, therefore, to increase the risk of constipation. Some medications and some conditions that are more common in childhood can also lead to an increased risk of constipation, and we're thinking here of things particularly like Down syndrome, Hirschsprung's disease, and diabetes in children. Again, if it's short-lived, managing constipation in children can be simple and no cause for alarm. But if there are any other features that are abnormal, then it's important, again, to discuss the constipation for your children with your family physician or with a doctor. And this is particularly important if the symptoms have becoming chronic, that is, they're lasting for more than a couple of weeks. And it's worth seeing a doctor sooner than that if the constipation is accompanied by other symptoms or signs such as fever, vomiting, weight loss, bleeding, as we mentioned earlier, cracks in the skin or painful areas around the anus, and rectal prolapse, which is a condition when part of the rectal tissue will tend to drop down out of the anus and become evident. And this usually occurs when people strain or have to push hard, and this then pushes the lining of the rectum out and can be painful and uncomfortable. The treatment for children is often based around simple lifestyle measures, things like reviewing the diet and ensuring that they have adequate fluid and fiber intake, adopting a regular schedule for clearing or moving the bowels, and in some cases taking laxatives to try and promote good bowel habits. And these need not necessarily be stimulant laxatives. It's often a case of using osmotic laxatives, which we'll talk about later, that tend to increase the fluid content of stools so that they're easier to pass. Now, one of the worries for people when they have constipation is that they're going to have to go off and have a lot of unpleasant tests. And in fact, for most people with constipation, testing is usually not necessary. It's obviously important if it's causing problems to discuss it with a healthcare professional. But the important parts of managing constipation are really related to what we call the history and physical. So firstly is an understanding of the symptoms that are occurring, and this is where the history is important, is to work out what symptoms are producing the problems, what the symptoms are and how long they've been present, whether there have been any changes in medication, whether there have been any recent or past illnesses that might trigger constipation, or whether there's been any other changes in lifestyle, in diet, travel, stress, all of which can have an effect on bowel habit. And then a physical examination in the office to make sure that there are no alarm features, no obvious areas of tenderness or lumps or bumps on examining the tummy, and to make sure that there's no evidence of anemia or low blood counts. And it's really only when these things have shown something up that one needs to consider going on to other investigations. So most patients and most people with constipation don't need any investigations. The investigations that we usually start out with, if one is needed, is usually a simple blood test to make sure that there's no evidence of anemia or a low blood count. Colonoscopy is probably the best way of looking at the bowel if one thinks that there may be some inflammation or scarring that is causing the constipation. And occasionally we'll move on to other investigations, some x-rays to look at how quickly things move through the bowel, ultrasound examinations, and manometry is a way of measuring pressures in the lower part of the colon to see if there is a problem with outlet obstruction that we talked about before, when people feel the urge to go but are then not able to move their bowels despite straining. But in general, most of the time we don't need to do any of these investigations. And just for those who are worried, going to your doctor to say that you're constipated should not mean that you're suddenly going to be sent off for a colonoscopy. So if, as is usually the case, the constipation has no serious illness associated with it, what are the options and what are the things we can do to try and treat the constipation? Well, this next slide summarizes some of the initial measures, which are really based around diet and lifestyle. Eating foods that contain probiotics, that is, good bacteria, and prebiotics, which are foodstuffs that promote the growth of good bacteria. These are often sufficient to help soften the stool, speed its transit, speed how quickly it goes through the bowel, and lead to reduced problems with constipation. And the sort of things we're looking at here, yogurts, kefir, bananas, whole grain breads, and honey. There are foods that tend to make constipation rather more likely, and for some people, diets that are high in fats, that contain refined sugar, are likely to make constipation worse. And that's because these are high nutrient foods that are absorbed predominantly in the small bowel, which means there's very little left over to go into the large bowel to provide bulk, trap fluid, and give the large bowel something to work with to promote transit and ease constipation. The other thing is that drinks that contain caffeine, alcohol, or artificial sweeteners are also likely to reduce transit and slow down transit and increase fluid absorption, which can make constipation more problematic. In order to make sure that the stools are easy to pass, it's obviously important that there is sufficient fluid in the stool. If all of the fluid is removed, then the stools become hard and compacted and difficult to move along. So it's important to take enough liquids, and one's aiming to take between 8 and 10 glasses of liquid per day, but this does not have to be water. Water obviously is an excellent thing to drink, but juices, milk, soup, and in fact in reasonable quantities, coffee and tea are all reasonable contributors to the consumption of a healthy amount of liquid during the day. The other thing that's important, and we alluded to this with when talking about constipation in children, is to develop a regular lifestyle, because we and our bodies get used to a certain routine. And there are many people, and I'm sure we know people, who can wake up in the morning, have a cup of tea, and then they go to the bathroom. And part of that is related to the body's expectations and its adoption of a regular lifestyle. So for those people who have problems with constipation, particularly if they find that it's related to an irregular or unpredictable lifestyle, it's important to try and develop a schedule that allows a consistent time every day to relax and have a bowel movement, and then to marry that up to having consistent times every day to eat, so that one eats at the same time every day with a reasonably predictable diet and intake, and consistent sleeping patterns are also very helpful. Managing constipation is in fact part of managing a general healthy lifestyle. And so in looking after constipation, it's so important to look after your general health, avoiding smoking, limiting alcohol, and recognizing that time management and coping with stress are also helpful in dealing with some variations in bowel habit and some of the symptoms that tend to go with constipation, particularly abdominal cramping and bloating. Overuse of some laxatives can make matters worse, and this is in part because when one gets constipated, one often wants to deal with it and will take perhaps too many laxatives, which in the short term is a very good way of clearing the bowel out, but then with the bowel empty, one's likely then to go through several days when the bowel slows down, one doesn't have a bowel movement, and that sets up a cycle of being constipated and then taking laxatives and having diarrhea, and makes life uncomfortable, unpredictable, and tends to promote an irregular bowel habit. Adding fiber is helpful, and that's because the fiber will tend to trap fluid and bulk up the stools so that it's easier for the colon to move the stools along and to achieve a regular bowel habit. Now, we hear a lot about fibers. Fibers are generally they're plant derivatives. They come from a number of different plants, and it's the indigestible part of foods that constitutes fiber. Fibers are generally classified into soluble and insoluble fibers. Soluble fibers dissolve in water, and they tend to trap water in the digestive system and tend to bulk up the stool. And soluble fibers, sources of soluble fiber are listed here, including things like oatmeal, pulses such as lentils, fruits such as apples and oranges, nuts, celery, carrots, and pectin. All of these have soluble fiber and used judiciously will tend to trap water, dissolve in water, and bulk the stools. Insoluble fibers do not dissolve in water, and they tend to add bulk or roughage to the stool. They're not necessarily all of the bulk in stool. Much of that is the bacteria that we have in the bowel. But again, adding insoluble fiber tends to bulk things up. It provides some structure and traps also the soluble fibers, and again is helpful in promoting colon transit and helping with constipation, although generally insoluble fibers are less effective than soluble fibers for relieving constipation and IBS-related symptoms. Insoluble fibers come from things like whole grains, bran, seeds, and again, showing that there's crossover between soluble and insoluble fibers. There are also insoluble fibers in celery and broccoli, some fruits, root vegetable skins, and dark leafy vegetables. How much fiber should we be taking? Well, I think it's important to recognize as a background that most people, or many people in North America, eat much less fiber than they should. And that the average diet often has no more than about 10 to 15 grams a day. And the recommendations are that healthy adults should probably have somewhere between 20 and 35 grams a day of fiber. It's important to recognize, however, that although fiber is a very important part of our diets, it is not a good idea to suddenly ramp up the amount of fiber that you take. So fibering up or gradually increasing your intake of fiber is the best way to approach that. And that's important, therefore, to recognize what are the foods that contain fiber and gradually to introduce those in larger amounts into the diet. So introducing gradually vegetables and fruits, ideally with their skins. For those who are tolerated, whole grain breads, cereals, and pastas are excellent sources of fiber. Legumes and pulses such as beans and peas, and nuts and seeds. So the goal from this is about 25 to 35 grams a day of fiber, introduced gradually. And all of these then, the things that we've talked about, regular lifestyle, fluids, regular eating habits, and the introduction of fiber, all of these are lifestyle dietary things that can generally be managed readily by most of us in our day-to-day life. And that will deal with constipation in a large proportion of people without the need to move on to some of the pharmaceutical solutions. So this next slide addresses some of the what are called pharmaceutical or pharmacological solutions to constipation. And these are important for a proportion of people with constipation. What I've done here is to list the different types. At the top, we have bulking agents as laxatives. These may be associated with names such as methyl cellulose or psyllium, metamucil, and benefiber. And these are related to the fiber component of the diet that we talked about before. Stool softeners such as colace, docusate sodium, and docusate calcium are widely used. Osmotic laxatives, I think, are being used increasingly, and these are medications such as lactulose, which is an undigested sugar, milk of magnesia, and polyethylene glycol, or PEG, that trap fluid in the stool, bulk it up, and stimulate the bowel to move contents along. And then there are stimulant laxatives that can be bought over the counter, things such as Senna or Senacot, Bisacodyl, or Dulcolax. And then there are a number of prescription pharmaceutical agents, things like Resitran or Procalcipride, that trigger motility in the bowel so that it encourages the bowel or stimulates the large bowel or colon to move the contents along in an organized fashion. And there are a number of new prescription agents that are likely to come out over the next few years. So a lot of options from a lifestyle, diet, and fluid intake point of view to manage constipation, and a number of other medications, both over-the-counter and prescription, that can be used to treat constipation. So let's just go through these in a little more detail. As a general rule, it's a good idea to start off with the so-called gentler products, and that's where we look at the bulking agents. These are the psyllium and methylcellulose that I talked about to keep water in the stool, to add bulk, and stimulate normal bowel contractions in a normal or physiological fashion. There are then what are called emollient laxatives, or the stool softeners, things like docusate sodium and docusate calcium, that seem to trap fluid in the stool to some extent, but they also coat the particles of the stool so that the water is trapped within and doesn't get absorbed. These don't work directly as laxatives, like stimulant laxatives, so they will take time to work. And if you're prescribed these, or if you want to take these, then you need to know that you need to take them for several days before they'll kick in with their effect. Lubricant laxatives, things like mineral oil or probably cod liver oil, used to be more popular. I'm sorry, I went through that a little quickly. These, again, trap water in the stool. They're used much less widely, and they have something of a problem in that because they're oil or fat-based, they will sometimes trap important fat-soluble vitamins and reduce the uptake and absorption of these vitamins that can lead in some people to vitamin deficiencies. The group of laxatives that I think we're using more and more are what are called the osmotic laxatives. What's listed here is PEG 3350, or polyethylene glycol, that is like a starch that traps water in the bowel. It's not broken down, it's not digested, it just sits in the bowel and traps water there so that it loosens and bulks the stool up, and this leads to increased transit. It traps water in the stool and is very effective as a way of managing constipation. Again, taken in regularly in small amounts, it takes time to work, and it's therefore important to make sure that it's used in the small prescribed amounts on a regular basis. The last group of laxatives I think that we want to talk about here are the stimulant laxatives. And if you'll excuse me, this slide seems to be repeating itself. We're going to move on to stimulant laxatives here. And these are the things like Senocot, Senna, Bisacodyl, Dulcolax, and Aloe that seem to irritate or stimulate the lining of the bowel, whether it's the nerve endings in the bowel or the muscles in the bowel, so that the bowel contracts and move contents along. And these are generally very effective for acute constipation because they stimulate the bowel. They can also cause quite a lot of cramping and abdominal discomfort. And generally, we don't recommend that these are used on a regular basis, not necessarily because they're dangerous, but because they're really a short-term solution to something that is a long-term problem that's better managed overall by addressing diet and lifestyle issues. So what I've gone through are some of the level 1 pharmaceutical solutions, if you like, these solutions that are available generally over the counter. There are other things that can be used, enemas and suppositories that are inserted into the colon or placed in the colon through the anus into the rectum. And enemas are large volume liquid preparations that distend the bowel. They tend to lubricate the stool so that it's easier to pass, and they will also irritate, mild irritation to the lining of the rectum so that it stimulates defecation. Suppositories are medications that are put into the rectum and have the same effect, although they don't lubricate the stools to the same extent because they don't introduce fluid in the way that enemas do. These are really for only occasional use for people who have severe constipation that is acute, where it's important to clear out a large amount of stool. using this, using enemas and suppositories for most people on a regular basis is not necessarily the safest or most effective or indeed the most pleasant way of dealing with constipation. And for most people, level 1 solutions combined with diet and lifestyle are the best way to deal with constipation. Then finally, the group that I wanted to address, which I mentioned before, the prescription pharmaceutical solutions. At present, the most widely available is this prokinetic agent or promotility agent, procalcipride, which stimulates a programmed contraction of the bowel that moves contents a large way around the bowel and stimulates physiological movement of stool through the bowel, leading up to defecation and relief of constipation. And like the other sort of over-the-counter gentler medications, these medications are designed for long-term use and have been tested in large clinical studies to ensure that they are safe and effective. So prescription agents, things like procalcipride, target specific mechanisms to improve the contraction and motility of the bowel, and they generally have a very good safety profile. And in fact, most of them are better tested than most of the non-prescription medications. There are a number of things that one needs to watch out for. I mentioned before the alarm features or red flags, and so untreated constipation can be associated with a risk of complications such as hemorrhoids, which is enlargement of the normal hemorrhoidal veins. These are big blood vessels that are at the level of the anus and the rectum, and with straining or with increased pressure in the rectum, these veins can become distended, they can enlarge, and sometimes they will bleed either inside into the rectum, or they may prolapse or fall out through the anal canal and become noticeable externally, and these are what are called external hemorrhoids or piles. An anal fissure can occur with constipation, particularly in children, where straining and contraction of the anal sphincter leads to spasm and pain, and then with straining on defecation, the lining of the anus can become slightly torn or cracked, and this is an anal fissure which makes passing stool painful and therefore tends to create a vicious circle whereby one becomes more constipated because it's painful to move one's bowels, and that then leads to further constipation, which makes it more painful. Ticular impaction occurs when a large amount of stool gets held up in the rectum, and what happens is more stool comes down to join it, and the rectum and the colon continue to take fluid out of the stool so that it becomes progressively harder and more difficult to pass. That's fecal impaction. And then a couple of other things that are rare but can occur. One is rectal prolapse. So I mentioned before that hemorrhoids can come down. Sometimes with repeated straining, the lining of the rectum can come down through the anal sphincter and become evident on the outside. And then some people are thought to develop a lazy bowel syndrome. That is, that the repeated use of laxatives leads the bowel to become dependent on laxatives, so that without laxatives, the person will continue to be constipated. So I've covered quite a lot of ground with this. I hope I've been able to cover some of the things that you need to look out for. Some of the solutions that can be used to deal with constipation, and many of them don't require you to go and see your doctor or your nurse practitioner. But if there are any concerns, if you have any red flags, if the constipation isn't responding to treatment, then obviously it's important to talk to a healthcare professional. And this just lists some of the things that you may want to prepare before going to see your doctor or healthcare professional. I think it's important before you go and see your doctor to be prepared. And so that, as we discussed before, is having an idea of which specific symptoms are causing you most trouble, how long you've had the symptoms, what dietary and other treatments you may have taken to try and deal with the symptoms of constipation, and how well these different treatments have worked. It's also important if you have worries, if you fear that the constipation or the stomach pain is an indication of a serious illness, it's perfectly all right to discuss that with your doctor. They won't think that you're being a worrywart, and they can often address your worries, which makes dealing with the constipation very much easier. The other thing is to know what it is that you want, what's the main symptom, and which are the symptoms that you'd like dealt with. And do you have any preferences? Some people really want to work with diet and lifestyle changes. Other people have had so much trouble that they want to be able to get things under control initially with medications before they start to make some of the other changes that are needed to deal with constipation long term. So that's just, I hope, can give you an idea of some of the things that it's worth looking out for before discussing constipation with your doctor if you need to see your doctor. And I hope that what I've been able to summarize over the last half an hour or so gives you an idea about the fact that constipation is a very common condition that affects about 1 in 4 Canadians, that it's associated with a number of different symptoms. It's not just about how often you go to the bathroom, but that constipation can be associated with discomfort or pain, bloating and gas, difficulty passing stool, and a feeling of incomplete evacuation. It's important to know that chronic constipation is associated with an impaired quality of life. That's not to tell you what your life's like, but to a recognition that it is worth dealing with. It may not be life-threatening like cancer or like heart disease, but it makes many people, 1 in 4 Canadians, often very unhappy. And because it's so, for many people, there are a lot of different treatment options, it does not have to lead to suffering for so many people. Half of those who suffer from constipation are dissatisfied with their current treatment, and there are therefore significant opportunities, some of which I hope I've managed to outline, for improving constipation, for dealing with it, for treating it, and for improving your day-to-day life. So chronic constipation can be treated by careful attention to lifestyle measures, including diet, exercise, and health-related issues. For some people, using appropriate current medications or newer agents. It's important to avoid complications and to take proactive steps, some of which I've managed to detail, to try and prevent and treat your constipation. And if you remain chronically constipated, your doctor should look for other underlying diseases or other causes, although these are generally very uncommon. So I think with that, I'm going to hand back to Catherine. I hope I've addressed many of the questions that many of you had, but if you have other questions, I'd be more than happy to try and address them.
Okay, that's wonderful. Thank you very much, Dr. Armstrong. We do have a lot of questions and not a lot of time, so we'll try to power through a bunch of them that we have here. I'll try to group them together so that maybe we can answer several of them at a time. There's a lot of questions around fiber. So we talked about trying to get somewhere between 20 to 35 grams of fiber a day for the average adult, and that we want to gradually increase that because most people don't actually take in as much fiber as they should. So I have actually 2 questions that want to be asked here. One is, how do I calculate the fiber intake based on the food that I'm eating?
So there are a number of different ways. So foods that are prepackaged will often or should actually list on the label how much fiber there is and how much fiber there is per serving. So if you know how many servings you're likely to have, you can calculate how much fiber you're going to take. The other thing is, for those of you who are internet savvy, and I presume you all are because you're all on a webinar, there are a number of resources around, and I think including the CDHF website, which give information about fiber content of different foods. So there are a number of resources, and in fact, if you Google dietary fiber, there are a number of sites that will list how much fiber there is in different foods.
Okay, great. And then the other one that's related to fiber is that someone has said that they're already taking 20 to 35 grams of fiber a day and are still experiencing chronic constipation. So she's asking if the recommendation would be to further increase the fiber. So
I think it depends how much fiber you're taking. It also depends on how much fluid you're taking. So 20 to 35 or 25 to 35 is quite a range, and 35 is not an absolute upper limit. Many people, and probably, in days gone by, we probably had much higher fiber diets that were probably more in the 40 to 60 range. I think if you're tolerating fiber in your diet and there is room to increase and it doesn't make you uncomfortable, then particularly if it's already had some effect, it's worth continuing to increase. There isn't any danger for the vast majority of people in going over 35 grams a day. But if you do take it, then you need to take it and you need to increase gradually, and you need to make sure that you're drinking adequate amounts of fluid so that the fluid is trapped with the fiber and is able to bulk up the stools. If that continues to be a problem, in particular if you have symptoms that we talked about before related, which suggest outlet problems, that is you're straining, you get the urge to go, and it's actually difficult to pass, I would talk to your physician about this, because there may be a problem with outlet, and it may be that there's some muscle spasm or anal fissures or something else that needs to be addressed in addition to the problems with constipation.
Okay, great. And then there's a couple of questions about the different therapy options that you spoke about. So one is taking a laxative such as Restoralax, which is available without a prescription, is it safe to use on an ongoing basis?
My view is it is safe. Restoralax is one of the group of medications that are based on the PEG that I talked about, polyethylene glycol, or PEG 3350. And this is a white powder that has no taste. It basically traps water. It's not absorbed by the body. And in a way, it's a bit like taking a fiber. It's a bit like taking a soluble fiber that traps fluid in the bowel. So providing you're not taking huge amounts, providing it leads to more regular bowel habit, I don't see any problem with taking it on a regular basis.
Okay, great. And then the related question is, with slow transit issues, is the prokinetic agent a better aid over over-the-counter aids?
I think for slow transit, prokinetics, that's specifically what they were designed for. My view is that they need to be taken after the other measures have been tried, and they will be more effective if there's adequate fluid and fiber intake so that the bowel already has something to work with. And then using the prokinetic to trigger the inbuilt contraction mechanisms is likely to be more effective and is a reasonable way to go. Okay,
great. What is your opinion on colon therapy offered by naturopathic doctors?
I'm not quite sure what's meant by colon therapy, but I presume this is the notion of colon cleansing and clearing out the entire bowel. I don't know of any evidence that produces any benefit, and my view is it's more likely to be harmful than beneficial.
Okay.
Really, because what it does is it cleans everything out, and actually, as humans, we're designed to live with the microbiome, the collection of huge numbers of bacteria that we have in our bowel, and we live in a sort of symbiosis with them. So if we flush them out every so often, we're really not doing ourselves any good with that.
Okay, that's important to know. We actually get that question quite a bit through our Ask the Expert feature on our website. Another question that I'm sure lots of people have is, why does travel result in constipation, and what can we do to help prevent it?
There are a number of reasons why travel leads to constipation. One is that it leads to a change in lifestyle. So it basically leads to a disorganized schedule. It often will alter the timing of our eating. It'll alter what we eat. It'll alter how much we drink. Sometimes when we go on holiday, we'll have a couple of extra beers or a glass of wine, which may alter fluid balance. We have different sleep patterns. So all of those are likely to play a role in this. If we have air travel, then the air on airplanes tends to be dry. We don't tend to move around. And we may well become dehydrated if we don't drink enough fluids on the plane as well. So all of those can play a role. Long car journeys can play a role. If you're driving long distances, then you tend to avoid going to bathrooms until you get to the end of the day. We may not like moving our bowels in strange hotels or public washrooms. And then the other thing is that sometimes when we're on holiday, we may get tummy upsets, which will then alter the flora. They'll alter the mixture of bacteria that we have, and that can then lead to changes in bowel habits. Sometimes it'll start off as an episode of a tummy upset or a gastroenteritis, which will lead to diarrhea for a couple of days, and then after that, a proportion of people will then have constipation for a period of time afterwards.
Okay, great. Another question here is, how do I know if my constipation has hit a level that is risky and needs medical attention? I
think one of the things I said was that it's rare that constipation is dangerous. That doesn't mean you shouldn't go and see your physician. I think when I mentioned at the end that constipation is associated with reduced quality of life, it really is an indication that the symptoms of constipation are troublesome. They're troublesome to many people and to a high proportion of Canadians. So if your symptoms are troublesome and you can't get them under control, then it's reasonable to talk to your doctor about that. It doesn't mean that you have to hit a danger level or that you have to be worried that there's something nasty there. You have symptoms that you're not able to get under control, and there are a number of different treatment options that can be considered, and I think that's the point at which it's reasonable to talk to your family physician, not because it's dangerous or urgent, but because, it's important to get help.
Okay. And a lot of the things that we've been talking about is referring people back to see their family physician. I wonder, is it a good recommendation for people, especially when they want to go through the early stages of trying to treat their symptoms, to perhaps seek out the advice of a dietitian or a registered naturopath to give them advice and to help them get them on track to make sure that they are eating the right foods and getting the right fiber in the right quantity? And then does that help indicate that if they're doing all of those other things right, that they really do need to seek the help of a physician?
I think that's quite reasonable. I mean, I think many of the things we've described with appropriate resources like the CDHF website will help many people and point them in the right direction for dealing with their symptoms themselves. For specific advice regarding diet, fiber contents, or other things that play a role in symptoms, it's often very helpful to talk to a dietitian or to a naturopath to get advice. I think it's important, as when consulting anybody else, to know what it is you want. Because if you're trying to treat constipation, then finding out about the things that will help constipation is important. It is important probably also to make sure that you're not taking on a whole slew of other dietary or other lifestyle changes that may not be relevant to the constipation.
Okay, perfect. So we only have a couple of minutes left before we have to shut down for the evening, but I wanted to just point out a couple of things. There are a few questions that we weren't able to get to, but on the CDHF website, so www.cdhf.ca, there's an Ask the Expert feature. So if you feel that your question didn't get answered by the very complete overview that Dr. Armstrong gave for us this evening, please use the Ask the Expert feature to make sure that we get your questions answered. The other thing I wanted to point out is that CDHF has a smartphone app that works on both Android and iPhone that's free. It's called GI Bodyguard, and you can download it from our website. And that is a really excellent resource for you to be able to track what's happening with your stool. It'll allow you to say how many bowel movements you have in a day, whether you're constipated or diarrhea, if there's any blood, pain, what foods you're eating, how much water or other liquids you're ingesting, whether you're exercising, and it will compile all of that information into a report that you can share with your physician. So all of those things that Dr. Armstrong was talking about sharing with the doctor, you can be building that in a really quick, easy, private way using your smartphone before you actually enter into the doctor's office. So again, it's called GI Bodyguard, and it is free, and it's available for Android and iPhone. We've also got a section on our website called Love Your Tummy, and there's a specific fact sheet on how to prevent constipation. And again, it's one of those for people who are suffering from occasional constipation. It's got some just general information that you can follow and hopefully get some help there. On behalf of the Canadian Digestive Health Foundation, I'd like to thank Dr. Armstrong for sharing his insights and expertise with us, Janssen for sponsoring this event, and to you for joining us. We hope you feel that this session has empowered you to better understand your options for managing chronic constipation, and that you have a wonderful evening. Thank you for joining us.